Hi, everybody. This is Dr. Marcelo Matiello. I'm here broadcasting from Mass General Hospital. I hope a lot of people will be joining this conversation today. And I will get text messages from Sumaira herself to let me know whether it's working well. I'm a neurologist here in Boston, and I dedicate my career to studying and treating neuromyelitis optica. Today, we will continue the series COVID-19 and NMO. This is a series that was created by the Sumaira Foundation and has a lot of different colleagues contributing to it. Michael Levy, Joshua Katz, Bart Chalice, and this was made possible by a educational grant from Viela Bio. Hopefully I'll get a text message soon from Sumaira to say it's working well, and then we can start the content. I see that 11 people already joined, and hopefully a few more will join before we get going. So today I want to talk to you about how we as neurologists diagnose and treat NMO. Gabriela, thanks for letting me know it's working. And I'll start with this vision of NMO 2020. So this should be a big year, and I think it still will be a big year for us. But as you go to a medical office and get your vision tested, a lot of times you hear from your doctor, your vision is 20/20, and that's good news. It means that from 20 feet away, you are able to read the small letters. And so this year 2020 should be a celebration year, and I tell you why. This is the first year we have opened a dedicated clinic for NMO at Mass General. And that's an effort from myself, Michael Levy, Gabriela Romanov, Eric Klauwitter, Gopal Vena, and many other colleagues who have put it together the effort to really use this year as the year of change, the year of improvement. However, we know that this year has not been easy. We were hit by this crisis of COVID-19 infection, and indeed has impacted everything we do, from our daily lives, how we take care of our kids or our seniors, how we take care of ourselves, and how we take care of patients. And especially today, we'll talk about how we take care of patients with NMO. So we will start by saying that treating NMO has become more complex, and that's for a good reason. We have more tests to diagnose the disease. We have more treatments. So when a patient presents to our emergency room with blurred vision, or numbness and tingling, or difficulty with movements, or bowel or bladder impairment, the first job of a neurologist is to decide, is this neurologic or not? And most often we know right away. There are other conditions that can cause this, but most conditions are neurologic. The second step that we do very quickly is to localize where the problem is coming from. For instance, if the eye is blurred, there is difficulty with pain when moving the eye, it's easy for the neurologist or for the ophthalmologist to localize the problem to the optic nerve. Of course, there are many other tests that we do to assure that we are right. Also, if there is weakness of both legs with numbness and tingling, the reflexes are increased. The other tests that we do, we localize the problem to the spinal cord, into the middle of the spinal cord. What we say is a thoracic spinal cord. So after the first step, we say it's neurologic. Second step, we know where it's coming from. The third step is to define what's causing it. And we use a lot of clues from the history that we ask patients to provide. Did it come very quickly? Did it take a few days or weeks to cause the maximum disability? All of this help us think about whether the problem is indeed inflammatory, how NMO or MOG disease causes a problem, or the differential diagnosis. When we have a good idea, we go to testing. And that's a big part of what we're going to discuss today. The first testing that we want to do is the imaging testing. It's to obtain an MRI of the brain, an MRI of the optic nerves, an MRI of the spinal cord, depending on where we think the problem is. We avoid doing MRIs and other tests of the whole body because we want to target the location that we think has a problem. This is testing number one. Testing number two is related to blood testing. And for blood testing in these conditions, we want to test two main antibodies. The antibody is a small molecule that circulates in our body, but certain antibodies, we know what's the target. So these molecules or this substance in the blood in patients with NMO or MOG disease, we want to test for aquaporin 4 antibody, and we want to test for the myelin oligodendrocyte glycoprotein. It's a big name, but that's the MOG antibody. Those are simple blood tests, simple to collect, and most hospitals send to a different lab. Here at Mass General, we send to Mayo Clinic, and after a few days, they look under the microscope and they decide whether they realize whether the antibody is positive or negative. So done with this step, we put together everything that we have. We put together the knowledge about presentation, the neurologic exam. A lot of you have been through many of those. That includes vision, function of the cranial nerves, function of the muscles, and then we put the testing. So the testing, as I mentioned, the two main categories are imaging, the MRIs, and the blood work. There are a few other tests, and a lot of you have been through, some of you have been through spinal fluid testing. In that, we can also look for inflammation, we can look for antibodies, we can look for other problems that we wanted to rule out before we make a definitive diagnosis. There are tests for other conditions of your immune system. For instance, in a lot of the patients we tested for antibodies that are present in lupus or myasthenia gravis, rheumatoid arthritis, autoimmune thyroid problems, autoimmune liver problems. There are blood tests that we use to allow us to think about treatment. So we want to rule out that there are virus infections or there is already a problem with the immune system in terms of low levels of antibodies. And finally, there are tests that we even get so we can know how the specifics may look like in the future. For instance, we use tomographies of the back of the eye. We call this OCTs. We also use different techniques to look at the back of the eye or to look for color vision. We tested strength in many different ways. We tested gait. So all the testing give us a good picture. Nonetheless, every individual is different and will need a specific treatment depending on what we find clinically and with these tests. So we spent about 10 minutes talking about testing. I'll spend another about 10, 15 minutes talking about treatment, and then of course we'll go into the questions. I know that the best tool through this Facebook Live is indeed the messaging and the questions that come through live. And by the way, thanks again for all the messages. I see a lot of people that I know and I love. So thanks again for all the nice and kind messages. So talking about treatment, we divide treatment into two main groups. The treatment right away when someone presents with an inflammatory attack, optic neuritis, transverse myelitis, sometimes even inflammation of certain areas of the brain. For those attacks, we want to be very fast. We don't want to lose any time. So if one of my patients calls me on a Friday night saying vision is not working well, I'm having pain on my eyeball or pain when I look to the sides, and it looks like I'm looking through a frosted glass, I say don't waste any time. Either drive, have a family member drive yourself to our emergency room, or if you live too far, to the closer emergency room, or call 911. If that happens and a patient gets to our emergency room, our team in the emergency room knows already what to do. Of course, I get involved, or Michael Levy, Eric Klauwitter, Becky Gilani, Farah Mateen. We have a large group of NMO specialists. We are connected with the colleagues in the emergency room, and we want to start an anti-inflammatory treatment right away. The most common and the most successful to start very quickly is indeed intravenous steroids. We use a large dose, a dose that really goes everywhere in the body and puts inflammation down, keeps the immunity lower, and helps resolve and helps prevent damage to those areas. A lot of you have been through a procedure called plasmapheresis. And more than we learn about plasmapheresis, we know how good it is. Plasmapheresis is a technique in which the blood goes into a machine. A machine rotates 2,000 rotations per minute and separates what is the cells in the blood and what's the liquid part of the blood. The cells are placed back with a new solution, placed back to the patient, and the liquid portion, which contains the antibodies, the chemokines, the cytokines, the inflammation itself, is discarded. Many places, the plasmapheresis can be activated rather quickly. It's indeed the practice that the first day, second or third, the steroid dose is being done, and then as soon as we see that the steroids is not enough, a plasmapheresis is started. Other places that do not have plasmapheresis may use IVIG. The information from scientific studies is not as detailed as the information that we have for steroids and plasmapheresis. So this is number one, the relapse management. Number two, and which is started right after the treatment for the relapse is done, is what we call prevention treatment or immunomodulation, immunosuppression. That is the type of treatment that we use to avoid new attacks, to keep everybody safe, to keep everybody living their best lives, home and working and being productive and happy. For the longest time, we did this based on science, experience, and what made sense. More recently, since the year 2019, we have now information through clinical trials. So the first part, the one part that we did through experience, expert opinion, including many medications. And those medications were tested. They were tested by comparing how the patient did before and after the treatment. but they were not compared to a placebo, to a substance that does not have effect. Those are the clinical trials that were conducted last year, and we'll talk about them in a few minutes. So from the type of treatments that we know they work by experience and retrospective study, we have azathioprine, is a tablet, mycophenolate is another tablet, rituximab. Most of you indeed are being treated with rituximab, which is an infusion. There is a list of another 10 or 12 different medications. All of those came from other autoimmune diseases. So methotrexate and chronic steroids, cyclophosphamide, and many others. But those three that I mentioned, azathioprine, mycophenolate, and rituximab, were indeed the big three that we used in this era pre-clinical trials. Those medications are very good. They prevent relapses in a great majority of patients, but they have their own advantages and disadvantages. For instance, azathioprine needs to be in a very high dose, so it has a risk of developing infections or problems with the blood. Mycophenolate, it doesn't have as many issues, but may indeed have some problems in terms of side effects and long-term immunosuppression. And rituximab is also a very good medication that is done every 6 months. And in most people do prevent the relapses, but some others may not. So back 5-6 years ago, we were not very optimistic that we would indeed have a clinical trial for NMO. We thought that NMO is a condition that needed clinical trials, but we were not sure in the sense of companies really dedicating all the resources. We also treat patients, people living with multiple sclerosis. And in multiple sclerosis, there are many clinical trials. There are many, many different medications. But we were very happy and surprised when 3 different companies said, no, we think we understand NMO really well. And because of that, we can apply molecules, medications, that have a very high chance of succeeding. And when that's present, I think doctors and patients and researchers and companies, they get very excited, and they really, in NMO, conducted 4 clinical trials for 3 different medications. So one medication had 2 trials. Those medications are eculizumab, sartrazumab, and inebilizumab. So eculizumab is a medication that is given through IV and has a first month of frequent infusions and then infusions every 2 weeks. And that medication blocks what we call the complement. The complement are a series of proteins that after the antibody binds to the nervous system, the complement goes there and amplify the response and the damage. So by blocking complement, eculizumab showed to be very successful and reduce the risk by a whole lot of a new relapse of NMO. Eculizumab has been FDA approved, and in a lot of places, including here, we are starting to use and successfully so. Sartrazumab is an improvement of a medication that we had, tocilizumab. So sartrazumab is the next best thing of this category of medications. It's a medication that is done subcutaneous, so in a pen that patients will do underneath their skin once a month. And that medication blocks receptors for a molecule called interleukin-6, or for short IL-6. That medication is also very, very efficacious, very efficient, very safe. And right now, it's applying for FDA approval. So even if we wanted to try now, we could not, because it has not cleared all the paperwork and the steps that keep everybody safe through the FDA. We were hoping that this medication would be available sometime this year. We do not know yet, based on the delays that the COVID-19 crisis have generated. Finally, inebilizumab is a medication that also is improvement of rituximab. And why do I say that? It targets a similar piece of the B cells, but a piece of B cells or a receptor B cells of even earlier or more immature B cells. So perhaps it may allow the effect that the rituximab does to somewhat degree of more efficiency. Inebilizumab is also an infusion IV done every 6 months and also not FDA approved. So hopefully sometime this year, or if not possible, sometimes next year, it would all be approved. A question that we get often is how you decide with now so many options. And we always say it's case by case. Many things are important. First of all, is a patient who tolerates the therapy that they are on now? Is the therapy preventing the relapses? Is the therapy easy to the lifestyle? Is the therapy free of side effects or free of complications? Is the therapy available and affordable? If check all the boxes, we do not change. We say, things are going well. However, if some of those boxes are not checked, for instance, if a patient had even a mild relapse while on one medication, or the medication is really causing side effects and life has not been easy, in those situations, we then think about the new medicines. Again, if a patient just presents to us without any medication, a new diagnosis, the likelihood, if those therapies are accessible, is that we will try those first. Those medications do have clinical trial data, with the caveat that we know rituximab and mycophenolate are also very good and have very little side effects. So if everybody that's watching, I hope I didn't lose too many people, but please send your questions and we'll go one by one. I promise to read the question and try my best to answer as more specifically as I can. Thanks for Sumaira for your comment, and Tracy and Tom and Terence and Susan and Gabriela, who already have posted messages. Until we find questions from the audience, let me tell you the questions that I'm asked a lot of times by other colleagues, by neurologists or internal medicine doctors that do not see as frequent NMO and MOG disease. The first question that we get all the time about testing is, do people need both blood and spinal fluid? Is there any added benefit? And what we usually say that most people will need only blood. The likelihood to detect the antibody in blood is much higher than to detect the antibody in the spinal fluid. Of course, the spinal fluid help us to decide if there's any other problems that we don't want to miss. For instance, if there is an infection of the nervous system or there are growth of cells, it's important to use that, but most often we use blood only. The other question that I get often is it necessary to test for both aquaporin antibody and MOG antibody? And my answer is yes. Both antibodies can cause similar issues in the nervous system. So before we test for both, and we usually test right away, we don't want to test after someone had steroids or plasmapheresis. With that, we want to test for both and decide what type of condition and what type of antibody is present. Question, can people have both antibodies? We do not think so, or it would be extremely, extremely rare. Everybody that we have looked so far either have one or the other. Sometimes if both are low positives, it may be due to difficulty with the technique, and that's when we repeat the test. Another question about MRIs. Should patient have MRIs every 6 months or every year, or into a frequency that we don't we set as a schedule? And I do not think that's necessary. Of course, it's case by case, but indeed, in NMO, we don't expect silent lesions to happen or to matter for what we do in terms of treatment. For instance, in MS, we do MRIs every 6 months or every year because in that condition we see new spots in the brain or spinal cord, and we can use that knowledge to indeed know whether patients need new treatments. In NMO, we go a lot by the presentation or the symptoms. If the symptoms are similar or the same that have happened before with the same degree of issues, we do not think that the condition is active or therefore the treatment is working. If there are new symptoms, especially if there are symptoms related to NMO, that's when we want to repeat the MRI or we want to test the blood again and want to perhaps change the treatment. Let me go back to questions here. Yes, indeed, we have a lot of questions. Sorry. So the first one, what are your views of using stem cell transplant to treat MOG? Does having umbilical stem cells change your views? So indeed, we all would love to be in an era that stem cells are a revolution. We are not there yet, unfortunately, and the complex part of this is that indeed the nervous system is the most complex tissue. So for instance, if you do stem cells to regenerate a muscle, there's one or two types of cells that need to be regenerated. In the nervous system, you will need to regenerate neurons, astrocytes, oligodendrocytes, and hope that the blood vessels are working well with the blood-brain barrier. So indeed, I would say for all the conditions that we treat, stem cell transplant, as is today, has one major application, which is to reset the immune system. So not the stem cell treatment that regenerates the tissue itself, but the ones that we use chemotherapy to vanish the immune system and replace with a new immune system with stem cells. Unfortunately, there are risks about this, and because the other treatments work so well, we do not use this as for second or third line, and indeed use for very late in the treatment scheme of things. Another question, what new treatments are currently in testing or about to begin testing for MOG? How many months, years before we start seeing new treatments? That's an excellent question. Thanks. MOG has two different, in our minds, has two different types of MOG disease. One, that it's a one and done. So a patient may have a optic neuritis or transverse myelitis and no recurrence. The marker that we have is that antibody goes away. So if you test positive, we start patient on steroids, second time we test, it's negative. We have seen many people doing well. For the people that have permanent antibody present in the blood, we use similar treatments to what we have used for NMO, with the caveat that we are seeing more patients that do not respond well to one therapy. So for instance, rituximab in NMO is 80-90% efficacious. In MOG, it's 70 to 80%. It's still very good, but not as good. And in some patients, we do need a combination. The specific answer to other treatments of MOG will appear, no doubts about it. Unfortunately, we are in the infancy. We are talking to companies, we are talking to researchers worldwide, and we are putting together the efforts. No clinical trial have been started yet at Mass General for MOG, but as soon as this COVID crisis gets resolved, and we have a lot of energy and a lot of ideas. Next question. Have you ever heard of a patient who contracted NMO-SCD, spectrum disorder, as a result of papillary thyroid carcinoma? This is my case. The tumor was removed, and I have been receiving rituximab treatment. However, my doctors are unsure about how much longer to treat me with rituximab, or whether or not I have NMO-SCD for life or not, due to the lack of data, a case similar of mine. So thanks for the question. Indeed, in very rare situations, the NMO antibody can appear because of a cancer. Very, very, very rare, but possible. Two things in my mind are the reason. One is that in an environment in which there is a cancer in the organism, the cancer itself, the cells that are reproducing, multiplying itself, may express a lot of different proteins. And if the cancer cells express aquaporin, aquaporin 4, it may create an immune response to that aquaporin and unfortunately cause NMO lesions. We know from the examples of other perineoplastic or other immune conditions that are due to cancer that the main treatment is indeed the removal of the cancer. However, because NMO is it can be such a strong response, we usually keep patients on immunosuppression for a long period of time. In the future, in your case, with your doctors, you can ask to be retested, and there would be a decision point there to what's more risk to benefit. So perhaps with your doctors, you may decide to continue rituximab or give a holiday and see how things go. So I got a nice comment from Rita De Flaminis. Thank you. I hope you and your family and everybody that is listening here today is all safe and enjoying the bright side of all this. I know that every situation has its bright side. In my case, I haven't really spent much time at home, but I know that I've discovered a lot about my baby girl, Carolina, my wife, Erin, how wonderful they are. And they've kept me very happy, even though I'm in the hospital all the time and learning and treating patients with COVID infection. Oh, hi, everybody. And Kathy, Patty, Maureen, hope you're all doing well. So a question from Gabriela. Is it common for patients when taking Solu-Medrol to resolve in the first few days? If not, how do you determine whether to add plasmapheresis, or plaques for short? And one more question, for what conditions do you recommend adding IVIG? Thanks, Gabriela. It's a terrific question. In our experience, patients with the MOG antibody may respond very quickly to Solu-Medrol, to IV steroids. So in a day or two, things can be much, much better. In NMO, it may take more. In the past, the studies with plasmapheresis waited for a full week, 5 days of steroids, then another week. If things were not improving, then they would do plasmapheresis. We now wait a day or two. Sometimes if things are improving, we may wait another day to add the plasmapheresis. What we're seeing that by bringing this early on to the treatment, it's probably better. Again, would a patient improve without plasmapheresis? We lose that capability if we add right away, but we think that it's so important to treat with the best regimen. The second question from Gabriela is about IVIG, and indeed we're seeing more advantages to use for patients with MOG conditions that did not respond to first line. So for instance, if the patient did not respond to rituximab or mycophenolate or a combination of both, we add IVIG. In NMO by aquaporin antibodies, we have not seen a big need. Of course, there are patients that did not respond to many of the medications, but we think that IVIG so far has been more useful in treating MOG patients. Then a comment from my wife. Thanks for watching. I hope you're not too busy in the hospital. Thanks for all you do. Should I get blood prior to my Rituxan infusion? And most likely, yes. Of course, every case is different. But in most patients, we do want to know right before you get the rituximab, the levels of your B cells. And that tells us whether the 6-month interval that we are doing is indeed right. So Michael Levy and other colleagues, Maureen Milley has been on those studies as well. Colleagues from Korea, they've looked into whether rituximab could be spaced out more or needed to be brought closer together, and that blood work that we do right before help us. Again, almost all patients are just fine with the 6-month interval, and very few will need to have it more frequently. And the question is in the same subject. Can we make the gap for rituximab infusion more than 6 months? And if yes, how many more? So, indeed, in countries where there is a need because of a lack of a rituximab for everybody, for instance, or a lack of support from insurances, investigators have looked into testing B cells every month, and until the B cells are 0, they go another month without redosing rituximab. In practical aspects, that could be a problem. Say, if the blood test doesn't work well, or people go on vacation and they don't have the monthly blood tests. So what we have seen is that this interval of 6 months is safe, it works, and in some ways it's simpler to implement than testing the blood and checking and making sure that the B cells are gone every month. Of course, it's case by case. If in your case the 6-month interval is not convenient, you can talk to your doctor and try to perhaps look for a similar protocol. Thanks, Maureen. I'm staying safe. I was indeed deployed to work with COVID patients last week. It was a full week of intense learning and indeed very important and very satisfying to help. We have not seen any crisis like this, and I know all of you who are healthcare providers in this Facebook Live. You all have a mission, and thanks for everything that everybody is doing, from the nurses and physicians and physician's assistant, as my wife is a PA at the Brigham Hospital, to the people that are keeping this place safe and clean, and to everybody at home that have changed your routine to help combat this terrible infection. My big thank you. Going back to the messages, the initial MOG test for a 18-year-old girl and a retest 4 months later were positive. What is the likelihood that MOG will disappear in their lifetime, meaning monophasic? Terence, this is a wonderful and very important question for which we do not have certainty. As you probably are aware by now, we do not know why some people develop these antibodies to begin with, and why some people, these antibodies go away and why some people do not. People are looking very closely, even here at Mass General through Michael Levy's work, looking into how animals developed this type of immunity so we can test the treatments. So it's not certain. The best to do is to, along with your doctors, keep a person who tested MOG on treatment to avoid a new relapse. Another question about timing of rituximab. Is it common for individuals to need rituximab more frequently than 6 months, say every 4 or 5 months? And if someone does get put on this regimen, is it safe? It's a terrific question. As I mentioned, there are a few people that will need more frequent, and we have not seen any change in safety. We've seen people in even shorter regimens for many years, and if they're healthy otherwise, if they're taking good care of themselves, they should do well. They should be safe in terms of risks. So again, it's important not only to rely on the effects of rituximab, but also everybody, including myself, we all need to take good care of our bodies. It's important that we eat well, sleep well, that we have a good lifestyle with hobbies and a lot of social interactions. Social is good, even though we're distancing it during this time. But I often fail, and I remind myself to talk to my patients and talk to myself about how important self-care and wellness for all we do, for life and for management of health conditions. So, question for Andrea, from Andrea: what causes brain fog for those who have MOG? Does this also happen a lot for those who have NMO? Andrea, brain fog is real, and I hear from patients with different conditions. Unfortunately, as the name says, it's not well defined. Some people have fatigue, tiredness. Some people have difficulty with sleep, and then causes the brain fog. Some people may have chronic pain, and that leads to depression or anxiety, and that also interferes with the sharpness. So my way to define brain fog is a new way that people are using their brains is different from before. So lack of sharpness or lack of attention and concentration. In each case, we go into all those factors that I mentioned. So it's difficult to say in your case what is, or the case of someone that you're asking for, what is indeed the reason for the brain fog. What I've seen that helps is indeed good lifestyle, keeping the condition dormant by using the medications or the practices that I've mentioned. Then we have a question. What is the highest level of B cells you have seen in a patient before the patient relapsed? I have had B cell count as high as 84, 12% without a relapse. That is also a very good question. Investigators have looked everywhere to whether levels of B cells or levels of antibodies, meaning not only positive or negative, but is it high antibodies, low antibodies, how that predicts a relapse. And the quick question, we don't know for sure. These high cells that you're mentioning, if you are in a medication such as rituximab, would show that the rituximab needs to do more frequently. Because we know that after it repopulates, meaning it's larger than 1%, the risk is increased. How much risk? It depends on a lot of different factors. And but we know that the risk is increased. So even though it's good that you did not have a relapse, it's important to readjust the therapy if that's applicable to you. And another question: what tests would you monitor? What tests would you do to monitor a patient who has stopped rituximab treatment? Would you test for aquaporin cells or antibodies, even if the patient only tested positive for aquaporin once before beginning treatment? That's a very individualized approach to your case. I think it depends on really whether the risk of relapse is there. I think blood tests are easy to do. In my own practice, I want to test them so we learn how things are going. So it sounds like if you're positive before and then negative, then testing in the future may also be helpful. Again, there is no one protocol that fits everybody. So there are many things in your own case that I may not know, and that's why talking to your neurologist is very important. One thing that I get asked is whether every NMO patient should have an NMO specialist or a general neurologist would be just fine. I do think that having expertise on this condition is very important. And again, some general neurologists, they are super up to date. They go into our webinars when we teach in the academy meeting, or they're reaching out for questions. But it's not uncommon that if you live far from a center, that there may be two neurologists in your care. One that is locally, that's available for frequent interactions, and there is the specialist in a larger center. In the past, patients had to come here, or the interactions through video visits were not as good, but we do have that capability, and many other centers have too. So it's important to add that level of expertise, of course, if needed. Again, some other neurologists out there have a terrific experience and knowledge. Another question, is it feasible and is it practicable to have an oral version of rituximab? And if so, are you aware of anyone working on an oral version? Indeed, there are subcutaneous versions not available or FDA approved for us to use. And there is one medication that it's not a rituximab-like, but also blocks B cells. Those are called the BTK medications. They're being tested for MS. And if they're approved for MS, it's possible that they are also useful with rituximab, as useful for NMO as rituximab is. It's an interesting question. For instance, in people living with MS, I often talk about orals and infusions, and a lot of people like the orals because they can go and take and so on. But usually the orals are once or twice a day. And a lot of people like the convenience of coming here every 6 months or going to infusion centers. And they feel like that's easier to do. So even when a B cell treatment is available orally, we may rely into patient preference of what makes most sense. A question from Lisa. What is the difference between MOG and NMO? So there can be a very variety of different lengths of answers. So let me try to explain you the most summary wide possible. So NMO, based on equiporin 4 antibodies, can lead to optic neuritis, transverse myelitis, and other syndromes or other signs and symptoms. And that's because of an antibody circulating that targets. So it's a small piece of your immune system goes through the barrier that protects your brain, spinal cord, the optic nerve, and targets this protein, equiporin. This protein is present in a cell called astrocyte. Astrocyte is a cell that keeps everybody happy in the nervous system. It helps with the water in and out of the tissues. It helps with removing toxic substances. It helps with managing the levels of potassium and other substances. So NMO by equiporin antibodies damage the astrocyte. MOG is a condition that also can cause optic neuritis or transverse myelitis, but the antibody, that piece of your of the immune system, goes and attacks a protein in a different cell called the oligodendrocyte. Oligodendrocyte is the cell that produces the myelin. So that's the major difference between those two conditions. Is rituximab a long-term preventive that is safe to use for a lifetime? The most data that we have, Corey, is indeed a decade, or even beyond a decade, and it has been safe for that long. Of course, everybody's different. If a patient is taking good care of themselves and they're not having infections and their blood tests look good, people can continue to use rituximab for a long time. If there are problems, doctors may look into the levels of antibodies, the presence of recurrent infections, and decide whether it's safe. Comment from Andrea. Thank you for the insights. Stay safe. Same to you and to all of your family. So question that every time I went to receive my rituximab infusion, my white blood cell count is usually high. This last time it was 13 point something. It is normal for people with NMO to have a high white blood cell count close to the infusion time. Corey, the important type of count is the B cells. The one count that you mentioned is the whole number of white blood cells, including neutrophils, eosinophils, and lymphocytes, and even the lymphocytes, the B, the T, and so on. So 13 doesn't seem to be very high. If it's higher than that, it's good to be tested for infections. Immune cells become high when there is an infection. But if in your case, it's difficult to imagine that this is of importance to manage your rituximab infusion. Of course, if the B cell count is high, then there is a problem. Question from Sabine. How can I change my lifestyle to fix my NMO, meaning have controlled B cell production as a normal person? This is what we strive to learn. Indeed, what we know is that the immune system is so complex that we don't quite understand why some immune systems are very, very reactive and produces lots of antibodies and some other immune systems are not. We know that people with good diets, they have better bacteria in their guts and they live without too much inflammation. So I would concentrate in terms of lifestyle to do that, but also lifestyle may mean that you have a good organization to go into your medical appointments, to be on seminars like this, to learn about the condition, to share and donate time and be generous with your knowledge to others within foundations and so on. So a lot of things that people do, usually everything that our mothers or grandmothers told us, how to live a better life. A question on timing again of rituximab. I have just been put on every 5 months. How long have you been on it? For 4 months. So I guess they're talking to each other. So let me go to the next one. So someone that was tested for aquaporin in 2006, a long time ago, placed on rituximab August 2006, and have been on it for 13 years, have had zero relapses and redosing every 9 months. So congratulations. You know, that's really what we strive. In how long can I be on rituximab? Potentially for life, meaning there is no formula that says there is a date that needs to be stopped. If it's working and if you're not having any side effects, you could continue. And I'm sure your neurologist would reassure that for you as well. So for someone with MOG positive, if they failed rituximab, what would you typically consider for next therapy? Again, Terence, that's very case by case. We have used, there is no clinical trial for MOG positive, so we have used mycophenolate mofetil, infusions of IVIG, and even prednisone as a more long-term consideration. A couple more questions before I think we need to go. We have 59 minutes. Thanks again, everybody, for coming in. Quick question. Is it okay to take high-dose vitamin C while on rituximab? Yes, they do not interact. Just be careful that your stomach is well protected. Vitamin C is an acid, and for people who have irritation of the stomach, you may need to protect your stomach. But indeed, very good to especially to prevent urinary infections. Vitamin D is terrific. And the final question, what routine blood test should I be getting while on rituximab? So that will depend on what you have gone through while this, but the routine blood tests look into your blood cells and presence of infections. Of course, as I mentioned, the important one in the blood cells is the total level and the level of B cells. So again, everybody, thank you so much for taking your time and learning. It's very inspiring that people like Sumaira and her team in the foundation have spent so much time to create this. And thanks for inviting me. I hope I get invited again. And they're doing wonderful things. So check their website and continue the messaging. There are other wonderful, wonderful foundations out there. The Guthrie Jackson, the Connor Bead Judge. Every foundation has its own style. They all work for to improve the information and to fund research. Again, thanks the sponsor of this program who helped the foundation put this all together. And again, be positive. I think we are America, or even if you're in a different country now, you know how resilient and how strong we all are as human beings. And I have no doubts that we'll be better off. So during this COVID-19, do not forget to get your infusions. Do not forget to touch base with your doctor, even through video or phone calls. And do not forget to take good care of yourself. Thanks again. Bye-bye.